Okay, this is Chapter 5 Neuro, and in this video we'll be discussing antiepileptics. So there are lots of different types of seizures and mechanisms that medications can work to control seizures, and so we basically, when we're choosing medication for epilepsy, we want to choose a drug based on how effective the drug is for the particular seizure type, different side effects that the drug may have, and whether the patient thinks that they will be tolerable or not, interactions with other medications that the patient is currently taking, interactions with other disease states the patient has, like definitely liver and kidney function, and then different lifestyle or patient preferences, which we'll get into later. So we're going to group the antiepileptics into traditional antiepileptics, which are older antiepileptics, and then the newer agents. So typically, when we think of older agents, we know that their efficacy in different seizure types is well established. We know their place in epilepsy and the different seizure types, and we know that there's been a lot of research conducted on them. Some cons to the traditional antiepileptics are that they're less well tolerated. They have quite a few side effects typically. They have complex pharmacokinetics, so there can be different things that happen with their distribution in the body and their metabolism and how they're absorbed, and there's quite a few drug-drug interactions as well. With the newer agents, the good things about them is that they're better tolerated and there are less drug-drug interactions, and they're typically thought of as being safer in pregnancy. But some cons is that since they are newer, their efficacy is less well established, and there's a lot less research that's been conducted on them. And there's a lot of evolution in finding exactly where they fit in efficacy in controlling seizures. So there's 5 medications that we'll be discussing today. So the first one is carbamazepine or Tegretol. And so we can think of this one as seizures being curbed or carbed by taking this medication. And then we can think of, if we think of the Tegretol, we can think of the ending as kind of like controlling the seizures. So Divalproex or Depakote, we can think of the val in Divalproex looking like vol in convulsions. And then Phenytoin or Dilantin, that will be the third of the 3 traditional antiepileptics. So then 2 newer agents are gabapentin or Neurontin and pregabalin or Lyrica. So both gabapentin and pregabalin contain GAB, but they don't actually have a direct effect on GABA receptors in the brain, which is one mechanism of action that anti-seizure medications typically use. So now we'll go over 5 practice questions regarding each of these drugs. And so the first practice question is: a newer antiepileptic that is a controlled substance that can cause rhabdomyolysis is... And so the 5 answers that we'll have for the remainder of the video is A, carbamazepine, D, Divalproex, C, Phenytoin, D, gabapentin, and E, pregabalin. So the correct answer is E, pregabalin. And so A, carbamazepine, Divalproex, B, and then C, Phenytoin are all incorrect because they are all older agents and they are all not controlled. Gabapentin is incorrect because even though it is a newer antiepileptic, it's not controlled and has less of a rhabdo risk. So pregabalin is correct because it is the only controlled substance, and it's controlled because of its potential risk of abuse. And then there is a risk of rhabdomyolysis, which is just the severe breakdown of muscle tissue. So now we'll go through 4 more practice questions, and we will keep all of the answers the same and in the same order, but we will change the question to make each answer correct. So an older antiepileptic that can undergo autoinduction and can cause a granulocytosis as well as a severe skin rash. And so the correct answer is A, carbamazepine. So B, Divalproex is incorrect because it doesn't cause autoinduction, a rash, or a granulocytosis. Phenytoin is incorrect because although it can cause a rash and a granulocytosis, there's no autoinduction. And D and E, gabapentin and pregabalin, are incorrect because these are newer antiepileptic agents. So autoinduction is a form of metabolism, and so basically the way carbamazepine works is it induces its own metabolism. So we'll initially see increases in serum concentration, but shortly after starting therapy, the half-life of the drug in the body decreases, which means that we're clearing the drug faster, and so this will lead to lower concentrations in the blood. Carbamazepine also has a black box indication for agranulocytosis as well as aplastic anemia, which are both just fancy words for saying that these are severe drops in white blood cells and in red blood cells. And then a severe skin rash. The skin rash is known as Stevens-Johnson syndrome, which can lead to skin sloughing. Practice question 4, make B correct. An older antiepileptic with side effects that include high ammonia, liver failure, and pancreatitis is, and so the correct answer is D, Divalproex. So carbamazepine and phenytoin are both older, but they don't have any effect on ammonia, liver, or the pancreas. And then gabapentin and pregabalin are both incorrect because they're newer antiepileptic agents. So Divalproex has a black box warning for liver failure and pancreatitis. Pancreatitis is just inflammation of the pancreas. So both of them would present as abdominal pain as well as nausea and vomiting, but then liver failure you could differentiate because that would present as jaundice, which is oranging of the skin. High ammonia, that just happens because of a buildup of ammonia in the brain, and that would present as confusion as well as nausea and vomiting. Question 5, an older antiepileptic that has a narrow therapeutic index and saturable kinetics is, and the correct answer is C, phenytoin. So carbamazepine and Divalproex both have a narrow therapeutic index, but they don't undergo saturable kinetics. And D and E are incorrect, gabapentin and pregabalin, because they are newer antiepileptics. So narrow therapeutic index just means that small differences in dose can lead to either therapeutic failure or toxicity. So basically the differences in the dose can lead to different blood concentrations, and just small changes can either lead to, instead of the drug work in its window of where it works correctly, it can tip it really easily into either not working at all, which would not control seizures, or having toxicity, which would lead to some pretty nasty side effects. And then saturable kinetics. So with most drugs, whenever we give a dose, the dose given is directly related to our blood levels. So if we increase the dose, we will increase blood levels exponentially. With phenytoin, it has nonlinear kinetics, so small changes in dose can lead to exponentially higher levels in the body. So we just need to monitor this more cautiously. So this might be something, especially with patient preference, if they don't want to come in and get their blood drawn often and undergo a lot of monitoring of this medication, then this one might not be the one for them, although it's been around the longest and it's pretty reliable. So practice question 6, make D correct. A newer antiepileptic that is also used for neuropathy is, and we'll select all that apply. So carbamazepine, Divalproex, and phenytoin are incorrect because they're older antiepileptics, and so gabapentin and pregabalin are both correct. So we see these a lot more for neuropathy and not quite as much for seizures. Like we discussed earlier, the newer antiepileptics are still kind of finding their way into where they will be used for epilepsy. And an interesting fact about a lot of the newer antiepileptics, most of them, when they were studied, they were first just studied as adjunctive therapy to the older antiepileptics, which we've already used for a long time. And so we're not really sure how these medications will work if they do, or if they're able to work by themselves. So that's kind of why they're not quite the front runner in seizure therapy, especially these two, since we just mostly see them being used for neuropathy or nerve pain.